Good morning. Welcome back to our class. The last session we have discussed about various antipsychotics, the mechanism of action. Today I am going to discuss with you the major adverse reactions. And as we know, the antipsychotics act mainly on the dopamine receptor. But in addition to dopamine receptor, it has got actions on muscarinic receptors, pyruvate receptors, histamine receptors, and the D2 receptors outside the central nervous system, that is in the enteric nervous system. And many of the effects can be explained on the basis of blockage of these receptors and neurotransmission. So let us look into one by one. One of the major side effects of antipsychotics is extrapyramidal reactions. The extrapyramidal syndromes vary from acute dystonia, including oculogyric crisis, Parkinsonian features, akathisia, that is a feeling of physical and mental restlessness, and tardive dyskinesias. This will be discussed in detail at a later time. And what is the mechanism of action? And as we know, the antipsychotics act by the blockage of D2 receptors. Here we can see the nigrostriatal pathways. So the nigrostriatal pathway blockage will lead on to extrapyramidal. Only when the dopamine receptors are blocked more than 75%, you get extrapyramidal reaction. So extrapyramidal syndromes develops when more than 75% of the D2 receptors are blocked. Between 60 to 75%, you get antipsychotic action. So depending upon the amount of blockage, you get the extrapyramidal syndrome. So a drug with anticholinergic action or addition of anticholinergic drugs will decrease the incidence of extrapyramidal reaction. The first generation drug haloperidol is very prone to produce extrapyramidal reaction. And risperidone, among the atypical drugs, risperidone is also well known to produce extrapyramidal reaction. The dosage and individual drugs we will discuss on another time. The second side effect we should remember is the sexual dysfunction. In females, this can produce galactorrhea, amenorrhea, which we have discussed last time. The mechanism of galactorrhea, amenorrhea is due to the blockage of the tuberoinfundibular pathway. That here, the dopamine acts as a blocker for release of prolactin. So when the dopamine receptors are blocked, there is excessive secretion of prolactin, hyperprolactinemia. This can lead on to gynecomastia in males. Patient can decrease libido, amenorrhea and galactorrhea in female. So this is caused due to the tuberoinfundibular pathway blockage. Then the D2 receptors are present in hypothalamus. Blockage of this can lead on to the neuroleptic malignant syndrome. NMS is a rare, less than 0.5 to 1% of patient can develop. It is a rare situation. It's a life-threatening condition. It's characterized by hyperpyrexia, Extraabdominal features, that is muscle rigidity, mental status changes, autonomic dysfunction. Two characteristic laboratory findings are: one is elevated creatine phosphokinase in thousands. Second is stress-induced leukocytosis. So, NMS is an important side effect that you should remember, and this can occur with haloperidol. It's well known. So, any patient on antipsychotics developing fever, think about the possibility of a development of neuroleptic malignant syndrome. Then the antipsychotics will act on the muscarinic receptors, and this will lead on to dryness of mouth, constipation, urinary retention. So muscarinics and glaucoma can be precipitated. So this point should also be kept in mind. Then some membrane effects. We know that antipsychotics are well known to prolong the QT interval. That is in the electrocardiogram. So if you draw the electrocardiogram, from the beginning of the Q to the end of the T, this is the QT interval. QT interval prolonged more than 500 milliseconds can precipitate ventricular arrhythmias, especially fatal torsades pointis. The prolongation of the QT interval is due to the blockage of the rectifying potassium channels. So potassium channels, once it's blocked, the repolarization is prolonged. So that leads on to prolonged QT syndrome, and that can lead on to various arrhythmias. So we have considered the Niagara striatal blockage, the hypothalamic blockage leading to NMS, the muscarinic receptor leading on to problems of dryness or the anticholinergic problems. Then other minor side effects are there. So among which very important for a typical antipsychotics is the metabolic effects. Many of the antipsychotics, especially the atypical antipsychotics, can produce diabetes mellitus, hyperglycemia and dyslipidemia. This is due to blockage of the 5-hydroxytryptamine 2C receptors, and this is very important in case of olanzapine and quetiapine, which are frequently used antipsychotics. So this is more common with the atypical antipsychotics. So the metabolic side effects of antipsychotics are predominantly, or it is more common for the atypical or the second generation antipsychotics. Then we have already said the membrane effects. They have got a tendency to precipitate seizure, especially the first generation antipsychotics. So patients on antiepileptics or history of seizures, you should be careful in selecting. And first generation antipsychotics, often used one is haloperidol. This can induce seizures. Then there is increased risk of stroke, especially when given for elderly more than 65 years. The incidence of stroke. So today we have discussed about the major side effects of antipsychotics, and second generation antipsychotics are more prone for the metabolic side effects. The individual drugs and dosage we'll discuss later. Thank you.